Welcome to the course on therapy in special education. I'm going to share my screen and we'll proceed through my portion of this course. So the outline for this course is that we will talk about types of therapy, purposes of therapy, evidence bases, and potential future of therapies. So who is Robin McWilliam? I am a professor of early childhood special education at the University of Alabama, the founder and director of the Evidence-Based International Early Childhood Office, which is EIEIO, founder of the RAM Group, an international group of experts on the routines-based model. I'm a trainer and consultant, and of course, a visiting professor at your university. Now, I have used Google Translate for translating these slides. So if you see something hilariously funny in the translations, blame Google Translate and me. You will need to organize yourselves into groups of 4. This course has 4, oh no, this should have been changed. It has 4 group assignments only, not individual assignments. By request, I've taken the individual assignments out. The purpose of the assignments is not to grade you. The purpose of the assignments is to give you opportunities to practice content that we've talked about, to reflect on content, and to expand your knowledge of the content. The group assignments are due by May 31st. I don't actually care about this date. They can be later if that's more helpful to you. But I had promised the instructors that I would concentrate my instruction in the month of May. And please email me if you need help. You can email me in Polish and I can figure it out. So you will be getting 7.5 hours of instruction, but these 7.5 hours include time in group assignments, recorded lecture time, live introductory and concluding sessions. That still has to be determined whether I will in fact have live introductory and concluding sessions. You will also have readings and videos to watch in English, sorry. I'll tell you now a bit about Polish subtitles for my lectures. So my lectures are recorded and uploaded to YouTube. And so you'll get the link for this recording. And you click on the YouTube link for the relevant lecture. Then click on the CC on the bottom right of your screen. Then click on the gear icon next to that. Then click on English auto-generated. Then click on auto-translate, and then click on Polish. You'll have to scroll down to get to Polish. And then all of the subtitles will be, for you, will be in Polish. All right, so make sure you look at these directions if you haven't ever done this before. I have posted some readings. Campbell et al. That's Pip Campbell, a well-known occupational therapist writing about models of service delivery in early childhood special education and early intervention. An article by Jennings, Lobo et al., Marturana. Yeah, this was not published, so there's no date for it, but it's a useful overview. and then an article by me. So those readings are in the Teams classroom, and I don't quite know what you want to do about them, owing to the fact that they are in English. So types of therapy. For this section, which is types of therapy, we're going to be discussing very briefly occupational therapy, physical therapy, speech-language therapy, early childhood special education, behavioral specialist, and psychologist. In the United States, the top four are the most common. Unlike Europe, we do not have a big presence of psychologists other than for testing, basically. And we are increasingly having behavior specialists, largely owing to the large numbers of children with autism who also have behavior problems. Occupational therapy tends to deal with fine motor skills traditionally. Occupational therapy came from the need to rehabilitate soldiers after World War I, where they came back injured, and this new kind of therapy was developed to help these war-wounded veterans to develop skills that they could use for their own recreation, or more importantly, for having jobs. So those focused on fine motor skills. They also deal with visual perceptual skills. They also deal with sensory processing, and that is quite important for quite a lot of children. And they, in the United States, often use sensory integration therapy or treatment. And this is one type of therapy that you need to be very, very cautious of, because it is controversial and the evidence base for it is a little suspect. Occupational therapists are also involved in making adaptations to usually things that are related to fine motor skills. So for example, they will build up the size of a handle of a spoon to make it easier for a child to hold the spoon while eating it. And they sometimes are involved in or helping with the development of splints to have the hand in the right position. Physical therapy is primarily engaged with gross motor skills, and those often fall into positioning and, of course, mobility. They also are involved in either helping with equipment or actually being the equipment providers. And they also collaborate with orthopedists. So there are some treatments that require an orthopedist, such as shells inside the shoe to keep the child's foot in the right position. So an orthopedist would be the one who would prescribe the orthotic, and but the physical therapist might be the person who brings that to the orthopedist's attention. And also the physical therapist would be involved in consulting with the caregivers on how to teach the child, well, how to put them on the child, and then how to teach the child to stand and walk with those orthotics. I'm just using that one example, but there are a number of other adaptations and pieces of equipment that orthopedists might be involved with. Speech language therapy. If you read English, you will sometimes, well, almost always, hear this, if it's from the United States, referred to as speech language pathology. In most other countries, they call it therapy. And so they, of course, are involved in language skills and speech skills. we have to be a little careful that if the children are very young, such as under 3, that we are promoting language over just out of context speech skills. They also sometimes use oral motor functioning, or can help with oral motor functioning, such as chewing and swallowing. The thing to be careful of with oral motor functioning is that it should be related to speech, because non-speech oral motor interventions have not been shown to be effective. They also, speech language therapists also are involved in communication by deaf and hard of hearing children. Early childhood special education. I have a lot of things listed here. They are involved in teaching strategies, because of course that's what they were trained in, specifically prompting and sequencing. They, along with speech and language therapists, are involved in interventions related to social relationships, play skills, engagement, independence, and really the whole child functioning. So whereas the previous 3 disciplines tend to focus on just certain aspects of the child's functioning, the early childhood special education teacher is really supposed to look at the whole child's functioning. That's not to say that an occupational therapist, a physical therapist, or a speech language therapist couldn't also look at the whole child, which is actually what we highly encourage. Early childhood special educators are also often involved in behavior management issues. Which brings us to behavior specialists. In the United States, we now have board-certified behavior analysts. So these people study for their board certification and have to take tests, and they can become board certified, which then makes them more marketable. In fact, now there are some jobs that require the BCBA. One of their roles is to conduct functional behavior assessments and to develop a behavior intervention plan. By our federal law that governs early intervention and special education, if a child is diagnosed with a behavior problem, then an FBA and a BIP must be developed. And then the behavior specialists also have various intervention strategies that they can consult with regular caregivers like parents and teachers on how to implement those intervention strategies. In psychology, there are essentially 2 types. I'm not sure whether they're divided this way in Poland or not. They are in the United States and in some other countries. There are the school psychologists who are primarily involved with testing, and they do some consultation to usually to classroom teachers, because these are school psychologists. Then there are clinical psychologists who are usually involved with mental health, and they also can help caregivers use various intervention strategies. We'll skip over the individual assignment. So your group assignment for this section is, as a group, come to consensus about which discipline would be most helpful in dealing with a family situation. In 100 words, explain your decision. So just one of you write the 100 words, get input from your group members, and I'll get one assignment in from your group. All right, I am going to pause the recording in just a second and get ready for the next section. Just 1 second here. Stop share, it'll be easier. All right, this section is about the purpose of therapy. And I'll give you an outline of this first. All right. We're going to talk about two approaches to therapy, a clinical approach and a consultative approach. The clinical approach is typically means working with the child one-on-one. It is usually out of context because a clinic room, a therapy room, for example, is not a natural context for the child's regular functioning. And we can talk about the physical context, but also the curricular context is different from what the child would be learning at home from parents or in the classroom from the teacher. Usually the therapist decides what we're going to do during therapy today. And that skill and the way it is taught might be have very little to do with everyday life. It might have little to do with everyday life. And often in a clinical approach, there is minimal communication with caregivers. Now, the problem with the clinical approach is the 7 circles. So I want you to think for a minute what these 7 circles might represent. What comes in 7s? Some of you already have it. Days of the week. So what do you suppose this little sliver here represents? That represents the time that the child spends with the therapist. And you can see that out of all of these hours of the week, this is a tiny, tiny amount of time that the therapist is, in some cases, working with the child. So then you think, where do young children learn? Well, young children learn throughout the day. Now, even if you were to take out the amount of time that the child is asleep, perhaps 10 hours a day, 10 to 12, you would still have a lot of what has come to be known by implementers of the routines-based model as the white space. The white space is where children are naturally learning already. Their learning opportunities are being provided by their natural caregivers, which would be parents and teachers, and sometimes babysitters and other people who spend enough time with the child to make a difference in the child's life, which is not somebody who sees the child for 1 hour a week or even 2 or 3 hours a week. And it's one of the reasons for this is that little children do not transfer or generalize skills very well. They're too immature to do that. So whereas you can take a lesson or even have a therapy session of some kind for yourself, and you can transfer whatever you learnt during that session to other times of the day, little children really don't have that ability. So we then have to think, well, then what should we do with the amount of time that we have supposedly with the child? Which takes us on to the consultative approach. The purpose of the consultative approach is to build the caregiver's capacity. It promotes caregiver-mediated intervention. So now we come to realize that one of the principles of this way of thinking is that all the intervention occurs between visits, because the visits are too short to make a difference to the child's acquisition of skills or developmental trajectory. So then it asks, well, all right, so if we're not supposed to work directly with the child, what are we supposed to do? Well, by building the caregiver's capacity, now the caregiver is in a better position to mediate or provide the intervention. And that in turn vastly increases the dosage of intervention that children receive. So in the consultative approach, I was just talking about vastly, yeah. In a consultative approach, let me just see where this leaves off. 1 second here. The intervention is contextual. The place where the child learns, places where the child learns, are naturally occurring places in the child's life, at home and in the classroom. The routines are routines that are naturally occurring in the home or the classroom. The agenda is the caregiver's. Actually, in some ways, it's the child's if we do use good incidental teaching. But the caregiver's agenda is more important than the agenda of a specialist who has limited time with the child and family. And so the child's interest, that's what I was just saying, is that should be very influential over the caregiver's agenda. So you can see that the clinical approach and the consultative approach are quite different. In collaborative consultation, that is how we interact with the caregivers, whereas the clinical, medical, and educational models make suggestions and recommendations and sort of expect the caregiver to carry those out. In conjoint behavioral consultation, this approach is called the expert model. Instead, we should collaborate with caregivers. So what does collaborative consultation look like? Sorry, this one didn't get translated. The family decides on goals for the child and themselves. We ask caregivers in what routines these needs arise. What times of the day are these child skills needed? We ask many questions about the context. We then make a suggestion, and we ask if the family is interested in that suggestion. We then ask the plausibility and feasibility questions. They are, do you think that this strategy that we were just talking about will work? And with all the other things you have to do at this time of the day, do you think you'll be able to do it? And if the family says, or a caregiver says yes to both of those, then we're good to go. If they say, really, I just don't think this is going to work, or I just don't think that I'm going to have time to do that, then we need to start over again, maybe at the next session, but we don't want to be left with our having an assumption about what the caregiver will be doing. And we don't want to leave the caregiver with something that the caregiver doesn't believe in. So these two questions, plausibility and feasibility questions, are important. Here are some example questions to establish context. The parent wants to talk about the child's using two-word combinations or whatever. We would try to find out during what time of day using two-word combinations would really help with the child's participation. Same with the teacher. And then, what is the child doing now? What do you want the child to be doing specifically? What have you tried? And when we come to making the suggestion, we say, have you ever tried, and then fill in the blank. All right, I'm going to pause the recording for a second here. Stop share first. Next, I've already talked about these, but I'm going to talk about them again. They are the plausibility and feasibility questions. I couldn't find Polish translations for plausibility or feasibility, so we just have questions here. The plausibility question is, do you think this strategy will work? And the feasibility question is, do you think you'll be able to implement this strategy? Now, a really important support for the consultative approach is the next steps form. The next steps form provides a space for documenting what we did today and any progress reported, what we will do from now until the next visit, and the plan for the next visit. Our paper version of this looks like this. So we call this the next steps form. This is what we did today and progress on any goals discussed gets written in here. This is what we will do from now until the next visit. And so this is the caregiver's commitment to strategies that the caregiver is interested in. And so I encourage people on the right-hand panel here, not just to say, Susie will provide hand-over-hand prompting to Johnny. Rather, I would say, Susie said she would provide hand-over-hand prompting to Johnny. So it's clear that this is by the parent, the caregiver's choice, not me giving the parent homework, which would, that would make me the expert who is telling people what to do. And we avoid that very much. And the plan for the next visit goes down in this box here. All right, so you don't have an individual assignment. Your group assignment for this section is, as a group, consider why Poland has such a strong therapy belief system, that more is better, more therapies, and more time in therapy. Find at least 5 references to support your ideas about why Poland is so therapy-oriented. And write your ideas in 100 words minimum in Polish. Okay, that ends the first 2 of the 4 sections, and I'm going to, let's see, let me make sure. Yeah, I'm going to stop this recording now and put the next 2 sections on another recording. All right, I'll see you in part 2 of Therapy in Special Education.